Okay, so you guys can see here our history of our patient, not trying to hide anything. He's a 54-year-old guy. He's coming in. He has a history of hypertension and recent COVID diagnosis. He comes to the ER with worsening chest pain and dyspnea. He was recently diagnosed with COVID in the ER and discharged home on 2 liters of nasal cannula. It's now about 2 or 3 days later that he's coming back in. He has diarrhea, fatigue, poor PO intake. He just felt like he could not manage his symptoms at home and therefore came back to the ER. In terms of his past medical history, he's got the history of hypertension, Meniere's disease, he's pre-diabetic, had an ACL repair, no tobacco, no alcohol use, actually is like an avid marathon runner. And then for his medications is on lisinopril and hydrochlorothiazide. Any questions on that first part? Okay, I'm gonna give you his vitals. So blood pressure looks okay, heart rate looks okay. He is 90% on 8 liters of high flow nasal cannula with a temperature of 99.1. An abbreviated exam, no acute distress. He's got 3-word dyspnea. He's got diminished breath sounds, no wheezing, no crackles, regular rate and rhythm, no murmurs, no edema. He's well perfused and he's diaphoretic. And then to top it off, I will give you his labs that they checked in the ER. So take about 30 seconds with your team, and I want you guys to each give me at least one problem per table that you'd be putting in your note for this guy that you'll be addressing based on his labs, his vitals, his presentation. Yeah, sure. You want vitals or you want his HPA? Okay. All right, so let's start with table 1 down here. What's one problem that you would put on your list?
Hypoxia.
Okay, and just hypoxia, or do you want to call it anything else? Yeah, he's COVID positive. Okay, so acute, oh, this is very thick writing. Let's change that. Okay, so acute hypoxic respiratory failure, secondary to COVID. Table 1, what's going to be something that you guys put on your list?
I was thinking it.
He's got other problems. You got to give me one.
Leukocytosis.
Great. And then table 3. I'm hearing Dr. Hellman say chest pain. Okay, great. So we know that he has a leukocytosis. That's abnormal. If he just had, pure viral pneumonia, we might not expect to see that. So perhaps we have to think about that. In terms of his BMP, his creatinine's at his baseline. There's nothing really going on there. He does have a slight liver injury. And then in terms of his trope, his BNP, that looks fine. I heard someone saying earlier protein gap. He does have that as well. And then in terms of his presentation, definitely acute hypoxic respiratory failure. He's barely satting 90% on 8 liters of high flow nasal cannula. And then the chest pain is also something important to make sure we don't miss in terms of working him up. Questions on any of that so far? Okay, so we're gonna move on to some of the laboratory data that the ER has gotten for us. So this is his chest x-ray. Again, take about a minute with your teams. And then if I could maybe have one of the acting interns walk me through what they think their read would be for this particular chest x-ray. Okay, do we have a brave AI that wants to talk us through their chest X-ray reading and get some candy? Excellent, love that. And then I'll actually give you the iPad. You can point out exactly what you're talking about.
So first thing we were talking about is that just looking at the airways, it looks like there's a deviation to the right. Specifically at Duchenne. Sinus processes, you can see them so be able to see. So it's hard to tell, it's just position. And then the next thing looking at is in the cardiac order, which to me that looks like this is a bit widened. We start losing the heart silhouette at the bottom of this X-ray. And then just kind of discussing the lungs, the fields themselves. We were talking about how there's pretty alveolar infiltrates throughout, diffusely, bilaterally. It looks pretty fluffy. And then kind of the last thing is that it's fairly difficult to see the costophrenic angle on this side. So potentially also some effusions.
Great.
Yeah.
You may take some candy for you and your team. Anybody have anything to add in terms of this X-ray? What's this thing going across the top? Does he have like some weird bilateral clavicle / shoulder implant? Yeah, so that's his high flow nasal cannula. It's that thick tubing that the respiratory therapist will bring into the room. So just be aware of that when you're examining your films. You always want to point out the others, things that are not human on our X-ray. And then I love how you pointed out, Sam, that you're looking at the spinous processes. We don't see them head on in his picture. If we did, they would look sort of like this. Should be like little circles staring back at us. They almost look a little bit more oval shaped. And so we know that he's probably rotated, and that's why the mediastinum looks a little bit wide or things look a little bit funky. But I totally agree that he has diffuse bilateral alveolar opacities or infiltrates. And so when you guys hear that term, diffuse bilateral alveolar filling process, what is the terminology that you think of? Anybody who was here yesterday maybe got a heads up on what we call that. Yeah, ARDS. So acute respiratory distress syndrome. Do you guys remember what the other factors are to say that something is ARDS versus not? Perfect, it has to be non-cardiogenic. Yep. Excellent, Roxana. An acute injury, less than 7 days. Yeah, and hypoxia, how do we measure that? Perfect. And so for all intents and purposes, we'll say that his heart is fine. It's not due to that. It's definitely less than 7 days. He had COVID diagnosis 2 or 3 days ago. We have the bilateral alveolar filling process. You guys can share. And then you know that he probably meets definition for hypoxia. He's on 8 liters and is barely saturating appropriately. Excellent. Any questions on the chest X-ray? Great. Let's move on to his EKG. And so we won't spend as much time on this. Take about 30 seconds. What I want to know is there anything super worrisome on this? Are you guys going to be calling cardiology for his chest pain that he's come in with, or do you think we're okay? Okay. Brave soul. Are we calling cards, being like, activate the cath lab, this guy has chest pain? Seeing lots of no's, right? No big ST segment elevation. We don't see anything super overt with his T waves or other evidence of ischemia. So we're good on this front. No major findings here. Okay, so let's get into a little problem representation. So I gave you guys his age and his past medical conditions. He's a 54-year-old male, history of hypertension, recent COVID diagnosis, who's presenting with. I want you guys to give me your problem representation. I want you to give me any other diagnostic testing that you want to do for this gentleman, and then what you're going to do to manage him. We'll go table by table, and maybe we'll start on the left-hand side with the problem representation. We'll do diagnostics here in the middle, and then management for table 3 at the end. So take about 1.5 minutes, 2 minutes to chat with everybody, and then we will continue on. Thank you. Okay, so let's start off. So table 1, anybody want to offer me a problem statement for this gentleman? Yeah.
Sorry, did you say problem statement?
Mm-hmm. Yep. So what would be in your assessment and plan, your overarching problem statement for this gentleman coming in?
Acute respiratory, acute respiratory failure on 8 meters high feet of flow, chest pain.
What was the last of it?
High heated, basically high heated flow. Yeah, high flow. High flow. Chest pain.
Okay. Anybody else want to add to that? Refine it?
You also said heated high flow, just touching on the high flow dysopenia.
Yep.
Which is what he's on, so.
Well, he's on high flow dysopenia.
Yeah.
That makes more sense for years.
And then
And then I would say that problem statements are more helpful if you can say like most concerning for.
Yeah.
So what are you all?
Yeah, most concerning for AR test. Yeah.
Excellent. Okay. Diagnostic testing, middle table. What would you guys do to work up this gentleman who's coming in?
We're going to get pulsatory blood filters.
Okay.
Then a CT.
Excellent. All right, table 3. What do you want to do to manage this guy?
So we're gonna place him on remdesivir index mechanism. I think we were talking about, right, considering moving to the ICU. And he's getting like respiratory therapy involved.
Great. Do you want to admit him to the ICU right now, or do you want to admit him to the floor?
I imagine if he's still on 8 liters, I would probably say intensity.
Okay.
And then if you guys look for it,
You're predicting the future, Sam. So this gentleman gets all those things that you guys wanted. I actually don't think that he got a pro-cal when he was admitted. They were pretty convinced that this was just COVID. He wasn't coughing anything up, but he did get worked up for infection. Repeat trope. CTPE is coming, but not done yet, perhaps. Dex and Rem were started. Respiratory therapy saw him, and he actually went to the floor instead of the ICU. So they can handle somebody who's on 8 liters and is stable on the floor here. Okay. Any questions on this so far? All right, let's keep moving. So obviously nothing ever goes as planned with an individual who is admitted for COVID. So the night that he's admitted, there's a cross-cover event. They're called to his bedside at approximately 12:15 in the morning. His oxygen requirements have increased to 15 liters from 8 liters following a 1-hour episode of coughing. The patient says he was comfortable. He was laying on his side. The coughing started. As he started coughing, he became more short of breath, more diaphoretic. He developed the chills. He was having the same chest pain that he came in with when he was coughing. And then during this whole episode, his respiratory rate was up in the 30s to 40s. Pulse was fine. Pressures were fine. And then in terms of his exam, the pertinent stuff to point out, so he's got increased work of breathing. He's diaphoretic. He's tremoring or rigoring in his lower extremities. And then in terms of his pulmonary status, he's got increased work of breathing. He has conversational dyspnea. There are crackles bilaterally, no new edema. And so pretend you are the cross-cover resident in this moment. What would you guys want to get? What would you order for this individual given his acute change from admission? And if you guys want, you can just shout it out. You don't have to wait to talk in groups. Great. So Sutton's going back to the basics, like ABG, chest x-ray, EKG. Anytime somebody has an acute hypoxic event or has a worsening hypoxia, totally accurate and something that you guys should all consider when you're getting called. Would anybody get anything different? Do you guys really want that CTPE now? Or are you still like, eh? Kate's like, why are you asking me again? I already told you that I wanted it. Okay, so I'm going to show you guys what was actually done. He was transferred to the ICU for a heated high flow nasal cannula. He got an ABG. Those are the numbers there for you. And then I laid out what the order is. So pH, PCO2, PaO2. And then the overnight person started tocilizumab. Who knows why we start tocilizumab? What's the data behind that? Or the indication for it?
People worsening within 24 hours after starting DEX, worsening hypoxia, being admitted on DEX.
Yeah, so there's Cochrane review. IL-6 blocking agents, so tocilizumab for our purposes, should be started on any patient who is admitted to the ICU within 24 to 48 hours of admission. And so for those of you who are working in the pandemic last year, our main things were just Dex and Ram, but now there is data on tocilizumab. There's a New England Journal article that was published in April of this year that showed no mortality benefit, but an overall Cochrane review demonstrated that there is a decreased all-cause mortality compared to placebo or standard of care, which is important there. So these patients were likely getting Dex and remdesivir already.
Sorry, so you add that after, so if you're not improving?
Specifically, if they are worsening to the point where they're admitted to the ICU. There is some data looking at if patients on the floor should get it, but the most strong evidence that we have is for patients who are admitted to an intensive care unit. All right, you guys ready to look at some images? I will start off on the left. I will loop it for you. So this is his CTPE.
Yes.
And it's going slow enough, we'll probably just watch this once. Okay. The slowest recording. I'm going to speed it up at the end here. All right. And then I'll show you his lung windows. And I'm just going to manually speed this one up too. Okay. Who wants to take a stab at telling me what's going on in these two images? First question, does he have a PE? Yeah, not a large one. We see his pulmonary vasculature here. Everything is patent. Yep, and you can see filling all the way out to the periphery, so it's unlikely that he has a big PE. And then what's going on in this lung window? Let's bring you up here. Yeah, so multifocal ground glass opacity is consistent with his known COVID ARDS. Okay. Questions on this? Seems a tiny big to me, but no known history of pulmonary hypertension or anything previously. Okay, let's keep moving. So he gets that scan, he goes to the ICU, he gets his tocilizumab. His hospitalization continues in a very typical COVID fashion. So he is hanging out on heated high flow for days, just sort of back and forth between lowering his FiO2, lowering his flow rate, coming back up. But then on hospital day 15, he has an increase in his oxygen needs. So he previously had been weaned down on his heated high flow, but he gets bumped right back up to 70 liters, 100%. He's more tachypnic in terms of his vitals. His blood pressure is stable. His heart rate is a little bit elevated. And then you can see his morning labs up on the screen. So take about 2 minutes and tell me, what tests are you going to order? What are you worried about? Why did this guy have a sudden change in terms of his clinical status? And why do you want to do what you want to do? Okay, let's start with table 3 actually. So looking at his picture, what's changed and what are you worried about? Okay, so worried about him. Are you worried about him protecting his airway, or are you worried about him not being able to recover from his hypoxia? Yeah, so worried about his hypoxia. He's alert and interactive, so he is functioning in that regard, not like somebody who's seizing or is altered, where airway protection is our indication for intubation. But yeah, so does he need to be intubated? Anything else that you guys are worried about? If no, that's okay. Go to the middle table. What are you guys worried about? Yeah, it's thrombocytopenia. Do you remember what his last values were? Do you want to see his trend? Okay, so this is where he was before. And then what are you worried about for his thrombocytopenia? Great. Okay. Excellent. Excellent differential there. And then table 1, what are you guys worried about in terms of his acute change? What do you want to do to work him up?
Also worried about hit, so I said that was on global as my Heparin, so I would stop that, switch it to either our Bachelor or add valve. And then check the antibody levels that people come back. And I would also get a COVID, a BNP, an EQG, probably another CCP as well.
Okay, Roxanne's gonna go the whole hog. We're gonna get all this updated studies on him. Excellent. So you guys picked up on a change for him. And I think that David laid it out really nicely. So this patient is acutely ill in the ICU. He now has a new thrombocytopenia and a worsening hemodynamic status. So he's more hypoxic, he's tachycardic. You're thinking about, is this HIP? Is this a new clot? Is it connected or separate? And so let's talk about that. So first, let's talk a little bit about how to think of thrombocytopenia for the inpatient. So for me, it's all about timing. So if I'm admitting a patient and they have chronic thrombocytopenia, that's this side of our differential. We're not going to talk about that for today because we have a patient with an acute thrombocytopenia. And so the way that I think about it is it has to be an acute change, so hours to days. And my first branch point when I evaluate somebody with thrombocytopenia is to say, what does their smear look like? And what are their hemolysis labs? Because if they have schistocytes and positive hemolysis labs, then I'm saying, do they have a MAHA or a TMA that needs to be worked up and likely needs an intervention that I cannot do myself as a medicine resident? Do I have to call renal for pheresis? Do I have to move to the ICU for that? Do I have to get the ball rolling on that end? If I do my workup and there's no evidence of, like major schistocytes, no evidence of major hemolysis, the next question that I ask myself is there evidence of clot? Because if there is clot, then I'm worried about a couple other things. So if the answer is yes, does the patient have HIT? Do they have antiphospholipid antibody syndrome? Do they have DIC that I need to worry about? If the answer to is there clot, no, then I look and say, is their smear indifferential normal? If it's not normal, so they have blasts, they have a pancytopenia, do I have to call heme and say, is there a hematologic malignancy going on? Do we have to do a bone marrow biopsy? But if their smear and differential are normal, that's when I start thinking about, Do they have a HIV and Hep C on record? What's their LFTs look like? Is there a lab error where there's platelet clumping and that's why it looks like there's acute thrombocytopenia, but it's actually normal? And so that's how I think about the acute thrombocytopenia in an inpatient.
I started thinking of some of those things as more chronic. Can you see in like Hep C inpatient, just like a sudden drop in platelets?
You wouldn't expect to, but let's say they came in, they were like very hemoconcentrated and then, you know, you resuscitated them and suddenly they've dropped their platelets, then you might be fooled by their admission labs. But you wouldn't typically expect to see an acute drop like that. Okay, questions on this overall? Okay, so what are we gonna do for this guy? So let's say we check hemolysis labs, they're all normal. His smear just shows decreased platelets. What do you wanna order next? And remember that he's in the ICU on max heated high flow. Do you wanna be the nurse taking this patient down for a CTBE on max heated high flow? Yeah, so we have some alternatives that we can do. We can say, you know, what about a DVT ultrasound, like upper and lower extremities, and see what's going on there. Lucky for you, the team did that. And he had a DVT involving his right upper femoral vein and left gastroc vein. So he's got bilateral DVTs. He has new thrombocytopenia. What's our diagnosis here? Or what do we have to do to confirm it? Yeah, so Roxana's like, we gotta check that hit antibody, we gotta get him off his Lovenox, anticoagulate him with someone else or with something else. Raise your hand if you have a good understanding of how the hit antibody test works. Do you guys want to review it? Okay, so I have a little schematic for you. Everything is color coordinated. So your platelets are the blue things, your heparin is green, your platelet factor 4 is in red, and then your hit antibodies, or your, not the hit antibodies, but they're PF4 heparin antibodies, but we'll call them hit antibodies for now, are in black. So the way that it works is that you have your platelets, they're hanging out. Platelet factor 4 normally hangs out inside the cells until the platelet is activated. And then for this particular patient, he was on Lovenox for DVT prophylaxis. So he has some heparin floating around in his body. And for him, he has these antibodies that are also hanging out. So what happens is that the platelet becomes activated, and this is a very basic version of what happens, but platelet factor 4 comes to the surface. And once that is exposed, these antibodies can then bind, and they preferentially bind this platelet factor 4 and heparin. And so what happens is that you get both thrombocytopenia, which happens by, I think, a different mechanism, and thrombosis. So you get all of these antibodies that sort of clump together and cause your platelets to not function normally. So the Elisa test, which is the first test that you send off, says, do these antibodies exist? So you're doing immunofluorescent staining to say, is this present? The reason why we do that is because about 3% of the population has these antibodies anyway, but they don't cause any harm. So the first thing that we get is our ELISA, and that says, is there the antibody present? Yes or no. If your ELISA is positive, what do we do next? Yeah, the confirmatory test. You guys know what it is?
Serotonin assay.
Yeah, your serotonin release assay. What happens here is that the lab takes the patient's serum and mixes it with platelets and heparin. And then we have to see, are these antibodies functional? So are they causing the clumping, or is it something else? And so, if you mix the serum and you mix those other factors and it again causes platelet clumping, then you can say, okay, now we have a positive ELISA, we have a positive SRA. We know for sure this patient has HIT. Now, like Roxana mentioned, or somebody mentioned, these tests don't come back right away. And so HIT is not a diagnosis where you can wait and just be like, oh, I'll wait until the test comes back and then I'll take my management action. So has anybody heard of another thing that we can use to help predict the likelihood of whether or not a patient would meet criteria for HIT? Yeah, 4T score. And so I try and remember like platelet factor 4T score. So it's like, numerical similarity for that. And so our 4T score is here. And so there's a lot of different stuff going on, but basically it's all about the degree of thrombocytopenia, the timing of the onset, does the patient have evidence of thrombosis? And then is there another cause that could describe why this patient has thrombocytopenia? So if you go through for this guy that we're talking about today, his platelets definitely decreased greater than 50%. He went from like almost 200s down to 80. For timing of exposure, so it was about hospital day 15. And so he would get at least a point for that. For thrombosis, we know that he does have new DVTs. And then for other cause of thrombocytopenia, we did a good med review. He has no history of liver dysfunction. There's really nothing else that's going on, no evidence of DIC. And so if we say none, he had at least 6 points to start us off, which means a high probability of HIT. Questions on any of that we reviewed so far? Okay. And so for this particular patient, his HIT antibody came back positive. His SRA is still pending, but I would bet dollars that it will come back positive as well. So like Roxana mentioned, we can't just leave him on his Lovenox, but we also have to deal now with his new thrombosis. What are you guys going to pick for anticoagulation? Okay, Bivalroden. Other options? Dabigatran? Apixaban? Great. Are there any things that we should not give him? Yeah, no heparin products. So no heparin drips, no Lovenox. Any others?
Eventually warfarin, but not the bridge and the bridge.
Yeah, excellent point. So alternative anticoagulation choices. We have parenteral anticoagulation on the left. We have oral anticoagulation on the right. I put warfarin on here in an attempt to trick you guys, but you can't use warfarin right away. Why do you think giving him warfarin as his anticoagulation would be a bad idea in somebody newly diagnosed with HIT? Yeah, exactly. He's already in a prothrombotic state. And so if we just start him on warfarin, we're only going to further exacerbate that. So he can be put on warfarin once he is bridged and if he's therapeutic on another agent. And then how long do you guys want to anticoagulate him for? Yeah, so at least 3 months of anticoagulation because he has DVTs, but also with HIT, you would anticoagulate him for 3 months if he's got clot anyway. All right. Anybody have any questions on all of that material? Okay, does the team want to give us an update on how the patient is doing?
Yeah, he was intubated a couple nights ago. He was on UDIFO for like 10 days or 15 days, however long it was. He was holding on really strong. Now he's intubated, but he's still healthy. He's like a marathon runner, vaccinated at baseline. The question is like, do we transition to ECMO because we think he would tolerate it and then maybe come off it in a better shape. But doing well. His PDF ratio was 45 yesterday. Today it's over 100.
Great.
Yeah.
Yeah, so if you guys were here for Natalie's talk yesterday, all the things that we do for ARDS, so low lung or lung protective ventilation from our ARDSNet trial, we're going to prone him, presumably.
He's prone now.
Can talk about paralytics.
He's on, yes, saturated. Yeah, he's on drip.
Okay, so he's paralyzed now. And then in terms of diuresis.
We did 40 places.
Great. So team is doing all the right things in line with our ARDS care that we talked about yesterday. And then never forgetting ECMO as our final option for the patient if needed. Fun fact, what animal does Bivalroden come from? Yeah, leeches. So that's why you sometimes still see them used in different procedures. I have placed leeches in residency. We can talk about it at another time. But yeah, so you can order medical grade leeches from the pharmacy in Epic if you're ever at the U. Okay, great job, guys. So we talked about this patient with COVID. We talked about COVID management, ARDS management review. We talked about HIT. Abby has anything to add about HIT, I will let him step in. Otherwise, really interesting case. You know, it's not common that you see like a proven case of HIT in your time necessarily. So.
Yeah, no, great presentation and great case for sure. Glad to hear you say, for those of you who met me, I'm one of my first year Moss fellows. My second month on the job, so also still learning. But it is one of these things where it's kind of it's like day one of fellowship. You should know about it, and if you don't, you should. And so for me, this is like the leadership case too, because this is the first case I've seen in fellowship. And the first thing I want to say is like great job by the primary team for picking up. I see firsthand what happens when you don't pick up it right away. The worst case scenario leads to an amputation. In the second, the worst case scenario is a recurrent clot like months later or years later when someone isn't known as having it. So there are implications. For a team here though, like if you're a house staff managing this person like on mission or overnight or sometime in the acute phase, right? Like why does it matter? I guess the way I think about these things, the way I thought about this as an intern present, like what's the worst that could happen? Or like what do I need to do? Like those are the ways you actually effectively think about these things, right? And so in this case, you know, shout out to the team for recognizing the acute thrombocytopenia. Shout out to the team for recognizing those associated with low NOx use and that they picked up a clot. So the 4T score, a lot of scores in medicine, a lot of them are worthless. This one's not. This one's actually pretty sensitive and actually really good at picking diagnoses. I don't know if you guys 4T him, but once you find the clot, like with those scores, each component is not very equal. So, you know, depending on where it comes from, it might raise your suspicion or not. So in the setting of like a clot, like really high suspicion, like gotta make a change, gotta let change at that point. If there's no clot, the other thing to remember is that it's called the 4T score, and a lot of T's is like thrombosis, but that's not the only thing to look for with that T. So with that T, it's thrombosis, skin changes, systemic symptoms like fevers, chills, hypertension. It's kind of like signs saying, hey, like something's off. I'm responding systemically. I'm inflamed, I'm pro-thrombotic, whatever. So that's like a point worth making. And then like so, what does it mean? If you don't recognize that this is due to like the heparin that was not spraying someone, they're going to keep clotting. They eventually will clot. It's a matter of time. It truly is hit. And then I think most important, like most people, you know, like once you recognize it, like making changes to stop the heparin product you, et cetera, most people like recover. One thing I hate to recognize is that the anti-PF4 antibody is transient. The response is amnestic. So what that means is this person who we probably have slam dunked hit on a year from now might show up at the VA and have negative anti-PF4. It's not recorded in the history that he actually hit or confirmed hit. The next team that's seen years from now might not realize that. And then, of course, the implications, right? So if he shows up a year from now and someone wants to put him on prophylaxis, like this could go on two ways. What else do I want to tell you guys? I think it's pretty
And I think the ICU attending put in heparin as an allergy for him.
Okay, perfect. I was just thinking about adding it to the process.
But yeah, definitely double check and add it as an allergy in the system. So that way future providers know it's a real thing that this patient had.
That's probably the same most important thing, to be honest. It's like, you know, for most of these patients, once they're out of the acute phase, just making sure that people recognize it. So, you know, because the antibody is amnestic. It's not, it may not last. A few points to make about it too. Like we say it, like when it's symptoms box, that you're in or outside the box. But it's also on a spectrum. Like, you know, there's a lot of people who are anti-PF4 positive or whatever have symptoms, low 4T. There are people who might have thrombocytopenia in the setting of heparin use and might not have antibody. So like there's a lot of truths unrelated with it. So just keep that in mind. But definitely like the 4T score, like I gotta say it's probably one of the more useful scores in medicine. So
Yeah, and there's actually two kinds of HIT, HIT and HITT. HIT is heparin-induced thrombocytopenia, happens in the first day or two of being exposed to heparin. No evidence of thrombosis. The patient will recover and be fine. And then HITT, heparin-induced thrombocytopenia and thrombosis, that's this patient. So he needs to get anticoagulation. He needs to be off of heparin products. This is the emergency that we're talking about.
Little piece of trivia / maybe that development states. For those who've heard about like the vaccine-induced thrombosis, it's kind of the same pathology pretty much. It's PF4 antibody mediated. So the vaccine, which is clearly not here. When you hear about the clot after the vaccination, it's this mechanism. It's real, it's documented. It's like 5%, like a 5% rate. So yeah, it does happen.
Okay. Great job today, guys. Don't